Hello, 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 SimKit listeners. This is Dylan War, and I am super excited to review a newly released set of guidelines that will hopefully provide some meaningful clinical management guidance to a common presentation in the emergency department. I, for one, learned a ton in preparation for this review, and I'm excited to share some of what I learned with you all.
That is, of course, the voice of our illustrious Dylan War, EM physician extraordinaire. I, Jason Hine, am going to be popping in and out of this podcast, doing some summary and take home points as Dylan reviews GRACE-4. Let's get back to Dylan.
Today, we are going to talk about the GRACE-4 guidelines. This is the fourth topic covered by this writing team, who's been putting out phenomenal work, tackling some of the most common presentations to the emergency department. Their goal and appropriately named acronym is to put forth guidelines for reasonable and appropriate care in the emergency department. And the goal of GRACE is to focus on conditions for which there's a wide variation in treatment, and ED-focused clinical practice guidelines don't already exist, and these conditions frequently come to the emergency department for revisits. They've covered low-risk recurrent chest pain, that was GRACE-1. They've covered low-risk recurrent abdominal pain, which was GRACE-2, and most recently in GRACE-3 covered dizziness and vertigo. Now, they have published guidelines to help guide us on alcohol use disorder, alcohol withdrawal syndrome, and cannabis hyperemesis management in the emergency department. We are going to run through the recommendations and try to offer some practical tips that you can take with you on your next shift. We also discuss these recommendations and some of the more practical aspects of clinical management with the board-certified critical care ED pharmacist from my previous training institution. So let's set this up. Why does this matter? So the top three forms of substance use disorders worldwide are 1, alcohol use disorder, 2, opioid use disorder, and 3, cannabis use disorder. Now, although opioids have garnered much of the attention, alcohol and cannabis affect millions of people, and the acute and chronic repercussions of their use frequently land them in the emergency department. And though definitive diagnosis of these substance use disorders can require specific DSM-5 criteria or screening tools, we actually don't need these labels to make a formal diagnosis or to treat these conditions in the emergency department. We have guideline recommendations for ambulatory and inpatient management of these conditions, yet there are key differences in these practice environments, from possible need for IV medication to lack of continuity of care with a single physician. At this point, no guidance to specifically guide our management in the emergency department. So the purpose of GRACE-4 is to summarize the available evidence regarding the ED management of these conditions and to work to provide an evidence-based framework for the evaluation and management of patients in the emergency department. And unfortunately, we do have to briefly touch on methods for their guidelines just to make sure we're all on the same page before we get and dive into the recommendations and good practice recommendations. So the GRACE-4 writing team is a diverse collection of addiction medicine specialists, emergency medicine physicians with advanced training in addiction, and grade methodologists. And what's one of the most unique things here are patient representatives who have lived experience related to alcohol use disorder and cannabis hyperemesis syndrome actually play a role in developing these guidelines. And that's actually a common theme in the GRACE initiative. It provides an invaluable perspective. What's the purpose of guidelines that don't appropriately serve patients? I think this is so valuable, having patients on the writing committee and the writing team to develop guidelines. Now, GRACE-4 recommendations were based on 3 distinct PICO questions. Each question had extensive literature review and evidence synthesis that dictated their assessment of the quality of the evidence and the strength of the recommendations. PICO question 1. In patients 18 years of age or older receiving pharmacologic therapy for moderate to severe alcohol withdrawal in the emergency department, does the use of adjunctive phenobarbital by any route compared to benzos alone lead to improvement in outcomes? PICO number 2. In patients 18 years of age or older who present to the emergency department with alcohol use disorder who are discharged home, does the prescription of anti-craving medication compared to no prescription improve outcomes? And then PICO number 3. In patients 18 years of age or older who present to the ED and are suspected to have cannabis hyperemesis syndrome, does the use of dopamine antagonists like haloperidol or droperidol or capsaicin compared to usual care, so like no treatment, lead to improved outcomes? Now that we've reviewed the PICO questions and their methods that guided their literature review and their appraisal, we're going to spend the rest of this episode breaking down the recommendations and their good practice statements, and we're going to kind of group everything into 3 categories. We're going to first start with alcohol withdrawal. We're going to then move to alcohol use disorder, and then we're going to touch on cannabis hyperemesis syndrome at the end. With each of these, we're hopefully going to provide you some key clinical management pearls and provide some takeaways that you can use in your next shift. Let's get started. Now, let's first dive into alcohol withdrawal, everyone's favorite presentation. And unfortunately, we have to touch a little bit on pathophysiology here in order to really understand our treatment management and figure out what we're doing with these patients. So let's review. So alcohol withdrawal is a consequence of a hyperexcitable state that results from abrupt cessation of alcohol consumption. You have chronic use of alcohol. This downregulates inhibitory GABA receptors and upregulates excitatory glutamate receptors. When alcohol consumption is abruptly terminated, all this excess glutamate activity sets your brain into a neurotoxic overdrive, leading to all of the symptoms that we classically recognize in alcohol withdrawal. So autonomic hyperactivity, tremor, insomnia, hallucinations, illusions, psychomotor agitation, seizure, and delirium tremens, and possibly death. It is the life-threatening nature of alcohol withdrawal that makes emergency department management so critical. Currently, symptom-dependent treatment with benzodiazepines is the first-line management of this condition. Benzos. However, phenobarbital is another medication that is increasingly used for the acute management of alcohol withdrawal, particularly in the ICU setting. Mechanistically, phenobarbital could be the better choice. It not only increases GABA signaling through a unique binding site distinct from benzos and alcohol, but unlike benzos, also reduces glutamate receptor activity. There has been some caution in embracing this medication, given the potential for serious side effects such as respiratory depression and hypotension, but this is where the GRACE-4 guidelines come in. They have recommendations for us based off the available evidence. So their first recommendation as it applies to alcohol withdrawal. In adult ED patients over the age of 18 with moderate to severe alcohol withdrawal who are being admitted to the hospital, they suggest using phenobarbital in addition to benzodiazepines compared to using benzodiazepines alone. This is a conditional recommendation for low to very low certainty of evidence. Of all of the recommendations, I think this one deserves the most discussion on their process and what they found in their literature review. So ultimately, in the review of the literature, the direct evidence supporting the use of phenobarbital in the ED is of mixed quality and highly heterogeneous. Ultimately, 7 articles were included in their analysis. There were 3 retrospective cohort studies, 2 retrospective chart reviews, and 2 RCTs comparing lorazepam-only treatment to phenobarbital-only treatment. And unfortunately, these articles differed on the severity of alcohol withdrawal, the total benzo dose administered, and the phenobarbital dosing strategy. Overall, treatment groups really did not differ on most outcomes. And, beyond the direct evidence, they also tried to look at indirect evidence from the ward and the ICU. And ultimately, in large contribution from this indirect evidence from the ward and the unit, the data does suggest maybe a small to moderate improvement in several outcomes, such as reduction in intubation and mechanical ventilation. It's also maybe a signal for reduction in ICU admission rates and length of stay, and a reduction in hospital length of stay. Of note, even though it isn't specifically mentioned in the recommendation, GRACE-4 in the review of the literature did not identify any evidence of increased adverse events, such as hypotension or increased intubation with phenobarbital use, although they do admit the evidence was of low quality overall. Despite the overall low quality and heterogeneous evidence, the GRACE-4 writing group ultimately decided a balance between desirable and undesirable effects probably favors adjunctive phenobarbital over benzo alone for the treatment of adult patients with moderate to severe alcohol withdrawal. Sadly, there really isn't any sufficient evidence for them to recommend any specific treatment protocol or algorithm, so nothing written in stone here to necessarily guide you in the emergency department. However, a common theme in the published reports is an institutional protocol with guidance on initial dose, subsequent doses, and monitoring needs. So they really stress that they don't have a protocol, but what was common to the studies they reviewed was this universal protocol present in that institution that was agreed upon by all of the important people in that hospital. Would also just like to note that I know it's something that people are excited about potentially in the future, but at this time, they weren't able to recommend the use of phenobarbital in patients being discharged from the emergency department based on the existing evidence. So where does that leave us? If they aren't able to recommend a protocol, what are we to do next time we're on shift? There are several dosing algorithms or protocols that are floating around in the literature. They're also mentioned in the review in the GRACE-4 guidelines. We also discussed the clinical management using phenobarbital as an adjunctive treatment with our ED pharmacist, Liz Tenza. And I think we have 2 broad categories that we can consider in terms of our dosing strategies. So in broad strokes, you have 2 options. You have either a fixed dose or a weight-based dose. If you're going to pursue a fixed dosing strategy, that would be 130 to 260 milligrams IV phenobarb with subsequent doses every 15 to 30 minutes based on clinical need to a max of 15 milligrams per kilogram ideal body weight. Now, quick pearl and something to keep in mind here, the onset of phenobarbital is about 5 minutes with a peak in 15 to 30 minutes. So if you have a severe case, you can speed up the redosing a little bit, shifting maybe closer to every 15 minutes than every 30 minutes. Option 2, the phenobarbital load, it's going to be 10 milligrams per kilogram of IV ideal body weight over 30 minutes, followed by 130 to 260 milligram aliquots every 15 to 30 minutes based on persistent symptoms. Now, just for emphasis here, if you utilize a weight-based dosing regimen, you really have to use the ideal body weight. This minimizes the risk of oversedation. Now, this can be calculated using MD Calc or integrated into your EMR order. If a patient is cachectic and their actual body weight is significantly lower than their ideal body weight, you can consider lowering their weight-based dose or just use their actual weight, given how significant of a disparity their ideal and actual body weight dosing could be. I know, we just gave you two different options and didn't particularly guide you on which one may be best for you. And as with everything in emergency medicine and in medicine in general, the decision to choose between one of these two it depends. Now, we did talk to our ED pharmacist, Liz Tenza, about this, and she does have some perspective that I think is incredibly valuable, and hopefully that may guide your decision making in the future. There are arguments to be made for weight-based dosing strategies and for the fixed dosing strategy. Liz Tenza tends to favor the fixed dosing strategy for several reasons, though there is the caveat that it may be institution dependent. For one, the best practice is for nursing to not compound medications at bedside if it is an emergency. So sterility, diversion risk, dosing errors. Those are all reasons that institutions tend to put weight-based dosing into the hands of pharmacy. So this could delay care. And on the other side of that, right, you have fixed doses, and these actually can be more easily stored in the Pyxis. No one's compounding it, it's safer, so you can more rapidly get it to bedside and administer it to patients who are in alcohol withdrawal. So that's perk number one. Now, number two, some patients achieve control at lower doses than that 10 milligram per kilogram load. You can actually stop when you achieve control. Weight-based dosing could, in theory, lead to oversedation, and if you stop the infusion given risk of respiratory depression or a change in mental status, it can be difficult to tell how much phenobarbital the patient received. So as with everything, you can always give more, you can't take it away. Our pharmacist's preferred strategy would be 260 milligrams for one dose and then 130 milligrams as the subsequent dose until control of the symptoms or until you reach about 10 milligrams per kilogram. The generally accepted max in 24 hours is 15 milligrams per kilogram, though there really isn't an established maximum. And I think this is really important. If you are getting to 15 milligrams per kilogram of phenobarb, whether it is with a load and follow-up aliquots or just the fixed dosing strategy throughout, if you're at 15 milligrams per kilogram, you should pause and reevaluate and consider another etiology of the patient's symptoms, because it may not be alcohol withdrawal if they're not responding to phenobarbital at this level. So we've talked about the protocol and how we may dose this medication, but there are two additional topics just to kind of touch on here within the umbrella of alcohol withdrawal that I think commonly come up, especially in the context of phenobarbital. So patients with liver dysfunction. Now, alcohol use and liver dysfunction kind of go hand in hand. So what do you do with a medication like phenobarbital that is primarily metabolized in the liver? And unfortunately, we really just don't have any evidence-based dosing adjustments that exist for phenobarbital with either cirrhosis or just generalized hepatic dysfunction. Now, this is important. Hepatic encephalopathy is a strong contraindication to phenobarbital use. There's this risk of a prolonged comatose state that comes along with administering phenobarb with hepatic encephalopathy. We really have to be sure the agitation is due to withdrawal and not hepatic encephalopathy in the case of these patients before you get phenobarb. So what about benzodiazepines beforehand? Right? This is a patient population that traditionally is getting benzodiazepines as the first line. And if you're not really thinking about phenobarbital up front, this patient may already have received several doses of benzos before you start considering adjunctive use of phenobarb. So what do you do about that? And there is a paucity of evidence, but preliminary data suggests that it's likely safe with no increased mortality. So phenobarb after benzos, likely safe. We just don't have the data to suggest it either way. So take caution in that. If you are concerned, conservative management could just be using those 130 to 260 milligram aliquots of fixed dose phenobarb rather than the 10 mg per kg load. So if you're cautious about giving phenobarbital in the setting of a person who's already received benzos, maybe just consider fixed dose phenobarbital so you can really watch their mental status and watch for oversedation.
Okay, so stepping in here for some high point summaries of the GRACE-4 recommendations with phenobarbital and alcohol withdrawal syndrome. So unfortunately, there's not enough data or evidence to recommend the dosing and discharge or oral regimen for people going home. What about patients coming into the hospital? First, use your benzodiazepines. Do not worry about the use of phenobarbital in addition to benzos. Your hospital might have an algorithm for lower dosing or incremental dosing if you're using benzos first, but you can use phenobarbital with benzodiazepines. The primary literature, the direct evidence, as they call it, based on emergency department care, relatively scant. What they found was a lot of indirect evidence from the ICU and inpatient services that phenobarbital is probably quite helpful and effective. What does it affect? It seems to decrease the number of patients needing an intubation, decrease the ICU length of stay, and decrease the overall length of stay. That's all great news. How are we going to dose it? There's two different ways that you can do this. You can do weight-based dosing or fixed dosing. Looking at fixed dosing first, it's 130 to 260 milligrams every 15 to 30 minutes for a maximum of 15 milligrams per kilogram. For the weight-based dosing, we are using ideal body weight, and we are giving a 10 milligram per kilogram load, and then using those additional 130 to 260 milligram additions as needed for symptom control. Back to Dylan.
Now, let's change tact and move on to alcohol use disorder. All right, so formal diagnosis of alcohol use disorder can be pretty challenging in the emergency department. Think about it. It often requires DSM-5 and probably more time than we have in the emergency department. Yet, practically speaking, someone who comes into the ED with consequences or harms of alcohol use meets the minimum requirement for the diagnosis. Medications for the management of alcohol use disorder have been available for decades, and anti-craving medications have been shown to be effective in reducing the amount of alcohol consumed and heavy drinking days, as well as increasing the number of days abstinent. But despite their effectiveness, uptake in prescribing these medications has been pretty abysmal, with only 5.8% of individuals receiving treatment for this disorder, despite 85% of people with alcohol use disorder engaging with the healthcare system within the previous 12 months. So based on the available evidence, the GRACE-4 team wanted to provide guidance on ED management of alcohol use disorder and offer some possible options for anti-craving medication in the emergency department. So this is recommendation number 2. In adult ED patients over the age of 18 with alcohol use disorder, they suggest a prescription for an anti-craving medication for the management of this disease for those who desire alcohol cessation. And this is a conditional recommendation for very low to low certainty of evidence. For this recommendation, the GRACE-4 group provides a prescribing algorithm for anti-craving medications for patients 18 years of older who present to the ED with alcohol use disorder and who are discharged home. And we'll touch on it a bit here, but we actually recommend going to our show notes or the document directly to review this protocol. Now, the GRACE-4 team breaks down this general recommendation for anti-craving into some more specific recommendations. So recommendation 2A is in adult ED patients with alcohol use disorder who are not taking opioids. They suggest naltrexone compared to no prescription for the management of alcohol use disorder to prevent return to heavy drinking and or reduce heavy drinking. And this is a conditional recommendation for low certainty of evidence. Now, naltrexone is approved by the FDA for the treatment of both alcohol use disorder and opioid use disorder, and it acts as a highly selective opioid antagonist to block endogenous opioids. And this is interesting, right? Because we think about this in the setting of opioid use disorder, but these endogenous opioids are released by alcohol when it's consumed. When you tamp down these endogenous opioids, you're reducing dopaminergic activity, and that reduces the feeling of reward associated with alcohol. So using an naltrexone can actually reduce cravings, prevent relapse by tamping down the reward pathway associated with alcohol. And a number of reviews and meta-analyses demonstrate the benefits of naltrexone, and the data does show fewer heavy drinking days and lower risk of relapse. And I know what you're thinking. You're like, naltrexone? I'm an ED doctor. How do I even prescribe that? And luckily, the GRACE-4 Ready team has your back because they have a couple good practice statements for the rest of these recommendations to help guide care. So for this good practice statement, a bridging prescription of up to 4 weeks into a follow-up with an addiction medicine physician, primary care physician, or other appropriate healthcare provider can take place is preferred. Monitoring of liver enzymes should be at the discretion of the provider seeing the patient in follow-up. For patients not treated with long-acting benzos for alcohol withdrawal in the ED, patients should be advised that sudden cessation of alcohol consumption as a result of anti-craving medication may produce acute alcohol withdrawal. These patients should be counseled to slowly taper consumption and seek treatment for alcohol withdrawal management should symptoms occur. And this is one heck of a practice statement, but I think it's important to highlight a couple key things here. One, they do mention the importance of follow-up, and I think this is critical for all of these recommendations. This is the type of patient that you need to be sure wants to pursue pharmacologic therapy, and two, can follow up with an outpatient provider in a reasonable amount of time. And for the writing group, it was 4 weeks. And two, I know it can be a little anxiety producing to start medications, but they give the onus to the outpatient provider to follow up liver enzymes. It's not something that we need to do in the emergency department. Now, recommendation 2B, in adult ED patients with alcohol use disorder with contraindications to naltrexone, they suggest a compressate compared to no prescription for the management of alcohol use disorder to prevent return to heavy drinking and or reduce heavy drinking. And this is a conditional recommendation for low certainty of evidence. So recommendation 2B here is for a compressate, and this is another first-line treatment for alcohol use disorder that the systematic reviews showed is superior to referral to psychosocial support alone. GRACE-4 noted reviews that showed increased probability of abstinence, a significant reduction of heavy drinking days, and reduction in return to use. Unfortunately, the mechanism of action is not fully understood despite its efficacy. The GRACE-4 writers note here that a compressate is for those with contraindications to naltrexone, and that would include one, those patients who have severe liver dysfunction because naltrexone is hepatically metabolized, and two, and probably more commonly, those with ongoing opioid use. We can't forget that polysubstance use is common, and we really have to screen patients for concurrent alcohol use disorder and opioid use disorder before initiating naltrexone, lest we precipitate pretty severe withdrawal. Now, to help guide us here, the GRACE-4 team hits us with another good practice statement, and this would be a bridging prescription of up to 4 weeks until follow-up, where renal function can be monitored with an addiction medicine physician, primary care physician, or other appropriate healthcare provider is preferred. GRACE-4 here is once again giving us the okay to send these patients home with this medication and compressate as long as they have appropriate outpatient follow-up. And they're stressing here that once again, that laboratory testing, in this case renal function testing, can be monitored in the outpatient setting. It does not have to be something that is obtained in the emergency department. Now, they have one final recommendation in this category, and this is recommendation 2C. In adult ED patients with alcohol use disorder, they suggest gabapentin compared to no prescription for the management of alcohol use disorder to reduce heavy drinking days and improve alcohol withdrawal symptoms. This is a conditional recommendation for very low certainty of evidence. Gabapentin has been studied off-label for alcohol use disorder, and the evidence that they find is really all indirect. But they stress that this recommendation, unlike naltrexone or compressate, is more cautious and really is reserved for patients with high self-reported withdrawal symptoms when they stop or reduce their alcohol intake, or for those patients whom the cost of naltrexone or a compressate is prohibitive. And another good practice statement for us for this recommendation. Given the known misuse potential of gabapentin, a bridging prescription, for example, less than 2 weeks, is preferable to long-term prescription. Patients should be cautioned about the sedative effects of gabapentin, and it should be prescribed with caution or avoided altogether in patients who use opioids. In patients with high self-reported withdrawal symptoms, when they stop or reduce their alcohol intake, consider prescribing gabapentin in addition to naltrexone or compressate, and you can consider a weekly dispensing interval for gabapentin prescriptions longer than 2 weeks. And a quick pharmacist pearl here, the dose in this case is higher than you would start someone for neuropathic pain and titrated quicker. Sedation in this context is less of a risk given these patients have fewer GABA receptors from all the downregulation in the setting of their chronic alcohol use. So in this case, doses start at 300 milligrams TID titrated daily versus the only 100 milligram BID TID slow titration we usually see with neuropathic pain. And that was a lot to throw at you, but don't despair. If you go into the GRACE-4 guidelines or into our show notes, we'll have a copy of their algorithm for alcohol use disorder and the way to approach these anti-craving medications.
Okay, so time for a quick summary on our anti-craving medications. We've moved from acute alcohol withdrawal syndrome to alcohol use disorder, and the GRACE-4 recommendations are for us to consider a prescription for an anti-craving medication. This can decrease the number of heavy drinking days, increase the likelihood of patients moving away from their substance use, which is fantastic. And they talk about a few medical options here. Their go-to is naltrexone, as long as the patient doesn't have a contraindication, i.e. taking long-term opioids or have opioid use disorder as well. And the dosing for that is 50 milligrams PO daily. An alternative therapy here, if the patient does have contraindications to naltrexone, is a compressate. The dosing is 666 milligrams TID. Interesting choice by the pharmaceutical company for that number, but this agent can be used as an alternative, paying attention to renal dysfunction. Now, they also talk about the use of gabapentin as an additive agent with these other two. which can also decrease the amount of heavy drinking days, and they put a conditional recommendation on this because of the potential misuse of gabapentin.
All right, so let's talk about our last segment here, and this is going to be all about cannabis hyperemesis syndrome. So a quick review here. Cannabis hyperemesis syndrome is characterized by episodes of frequent and severe vomiting or nausea associated with abdominal pain in patients who regularly and frequently use cannabis. Classically, these patients have improvement in their symptoms with hot showers or baths, though it's important to note this is not required for diagnosis of this condition. The legalization of cannabis in many states, its increasing popularity, and the increasing concentrations of THC have led to increased presentations to the ED for this condition. Ultimately, look, the treatment for this condition is cessation of cannabis use. You have to stop. But symptom control and supportive care must first be rendered in the emergency department before they can go about stopping cannabis use. Therefore, the question is then, what can we do in the emergency department for their symptomology and their presentation? Sadly, traditional antiemetics, such as ondansetron or metoclopramide, have had low rates of success in treating cannabis hyperemesis syndrome based on the reported cases. So the GRACE-4 team wanted to see what other options do we have for treatment of this condition, and they looked specifically at haldol, droperidol, and capsaicin. So recommendation 3A. In adult patients presenting to the emergency department with cannabis hyperemesis syndrome, they suggest the use of haloperidol or droperidol, in addition to usual care and like the serotonin antagonists like ondansetron to help with symptom management. And this is a conditional recommendation for very low certainty of evidence. On the review of the literature, GRACE-4 found limited available evidence. However, they found droperidol lowered the median length of hospital stay and lowered the length of stay to ED discharge. They found that haloperidol resulted in higher treatment success, reduced use of other antiemetics, and had a shorter time to discharge. In their review, all of the fears of QTC prolongation have not manifested in the follow-up studies with the droperidol. And beyond the literature here, anecdotally, and in my personal experience, both of these medications, haloperidol and droperidol, work very well for this condition. Dosing-wise, the ranges are somewhere between 0.625 milligrams to 2.5 milligrams of droperidol. I know I've personally used 2.5 milligrams as an initial dose with fairly good success. This is also a pretty timely article. In my training institution, droperidol actually rolled back out for a whole host of indications, especially nausea and vomiting, and particularly cannabis hyperemesis syndrome. And over the course of the year, there was a lot of uptake for droperidol use by providers, and from what we can tell, there haven't been any lethal episodes of torsades that have resulted from use of droperidol in the emergency department. And this article, talks about droperidol, but it also mentions haloperidol, and they actually recommend a lower dose of haloperidol based on the available evidence, so somewhere around 0.05 milligrams per kilogram, just given the higher risk of adverse effects, like all those extrapyramidal symptoms, with no improvement in outcomes at a higher dose. Practically speaking, for most adult patients, this weight-based dose is about 2.5 milligrams of haloperidol. And unfortunately here, we don't really have any good head-to-head comparison studies between haloperidol and droperidol, so we can't give you any specific recommendations in regards to which ones to choose here. Now, this may end up being institution-dependent anyway, given what you have available to you on formulary. Some pharmacies still may be somewhat hesitant to have droperidol on formulary, just given the black box warning for prolonged QT. Just note here that that is likely an overblown adverse effect, and either one of these medications is going to be safe and effective for this condition. Now, moving from haloperidol to droperidol to capsaicin. So recommendation 3B here is in patients presenting to the ED with cannabis hyperemesis syndrome, they suggest offering the use of topical capsaicin in addition to usual care to help with symptom management. And this is a conditional recommendation for very low certainty of evidence. And as mentioned here in their recommendation, the evidence supporting capsaicin was very limited in their review. There was some weak evidence suggesting patients who received capsaicin were less likely to receive rescue analgesics, but there's really no difference in length of stay or time to discharge. Thus, ultimately, the recommendation is based mainly on the lack of significant adverse effects, the low cost of capsaicin, and the ability for the patient to apply the medication at home after discharge. One thing the GRACE-4 team wanted to note in this recommendation is that capsaicin actually may not be on formulary in your emergency department, and it may need to come from pharmacy. So this ultimately could delay care. And if you think about it, if you have other medications that may be more effective, you could be harming the patient by delaying treatment, waiting for capsaicin to arrive. And in regards to capsaicin, the GRACE-4 writing team left us with some final good practice statements. So good practice statement 1 here is one member of this team actually emphasized the importance of recognizing that not all patients experience relief with this medication, and clinicians should really be prompt in escalating treatment for patients whose symptoms are not alleviated promptly. This person also emphasized that capsaicin should not be used for patients for whom it has not been effective in the past. This is basically them just saying, look, capsaicin may or may not work. If you lather it on them, please reevaluate and escalate care. It's not a miracle drug. Use other medications as available and as recommended. Their next good practice statement in this category states, in patients presenting to the ED with cannabis hyperemesis syndrome, benzos and opioids should not be used as first-line treatment for this condition and symptom management. In balance with the lack of evidence supporting the effectiveness of benzos and opioids in this setting, and considering prior guideline recommendations from GRACE for avoiding opioids in the management of chronic abdominal pain, opioids should be reserved for patients where pain is the primary concern, and in whom haloperidol or droperidol have not provided prompt relief. They believe the potential risks associated with administration of opioids as initial treatment outweigh any potential benefit. This good practice statement, in essence, says, give haloperidol, give droperidol, maybe try capsaicin. Don't give benzos or opioids until those have failed, as they're likely not going to be effective, and they really should not be first-line medications for this condition or for chronic abdominal pain in general. And finally, to wrap up this category, one final good practice statement from this team. These interventions should be used in conjunction with anticipatory guidance on the necessity of cannabinoid abstinence for complete symptom resolution. They found no published evidence that reduction in use prevents cannabinoid hyperemesis syndrome. However, there is some anecdotal evidence from their patient representative who does have a lived experience that suggests in some cases reducing use may reduce the frequency of episodes. If the healthcare team suspects cannabis use disorder based on screening with a validated tool, consider referral to psychosocial interventions and or addiction medicine specialists if available. In this guidance and statement, they also state that hydration and other supportive treatments should not be delayed to get haloperidol or give droperidol or give capsaicin. Clinicians really should educate patients on the rationale for the use of all of these medications if they're used, and really caution them about the intensity of burning that could be related to capsaicin application. Liz Tenza, our pharmacist, just wants to highlight that last point. Patients are going to apply this medication themselves either in the ED or at home, and there's room for error. And the biggest thing here is make sure patients have gloves when you send them home or when they apply it in the emergency department. Sinks are hard to come by, and you really want them to have gloves on because if they get capsaicin in their eye, you're probably going to have them coming back to the emergency department with a different complaint, and it's not going to be nausea and vomiting.
Okay, so a summary on the cannabis hyperemesis recommendations from GRACE-4. Yes, use your haloperidol. Yes, use your droperidol. They are great medications. They are safe. With the bringback of droperidol, we have seen that this is not a monstrous QT prolonging drug and works very well for this condition. These should be first line, especially over things like opioids and benzodiazepines. And you can consider adding the capsaicin cream as an adjunct therapy. You can use it first, but don't have it delay the obtaining of an IV, the administration of antiemetics, the administration of IV fluids. If it works for a patient, great. If it hasn't worked for them in the past, consider holding it.
All right, guys, we did it. We made it to the end of this review. Thank you for listening. As we dove into the GRACE-4 guidelines, we went through alcohol use disorder, we went through alcohol withdrawal, we talked about cannabis hyperemesis syndrome, and we reviewed the recommendations and the good practice statements by the GRACE-4 team for these conditions. We really did span the gamut today in this discussion, going all the way from phenobarbital to anti-craving medications to droperidol, haldol, and capsaicin. There was a lot of information covered here, and you can review a lot of this in the show notes or take a look directly in the GRACE-4 guidelines. I want to end here by applauding the GRACE-4 team in providing us these recommendations. Although the evidence is a little bit scant and it's a little bit murky and the waters are muddy, they really did their best to give us evidence-based guidelines for management of these important conditions in the emergency department. And that wraps it up here. Thank you for sticking around, and you guys have some key things you can take with you into your next shift. Until next time.
All right, y'all, there are our recommendations on the management of alcohol withdrawal, alcohol use disorder, and cannabis hyperemesis from GRACE-4. Remember that SimKit is here to help keep your skills sharp. We are delivering boxes of simulation materials for rare, high acuity, low occurrence procedures right to your door. Check out the link below for more.